Welcome. What's happening? Right. Okay, I don't know what happened there. So, welcome, greetings, and it's wonderful to have you all here for another day on Oral Pathology 360. And today we are going to be talking about a very interesting topic that's lichen planus. Now, lichen planus is a part of skin pathologies mostly, but of course, it has a oral manifestation. And what is interesting is that, like almost every problem with the skin, the oral counterpart also is very complex, and it has even added complexity because it can even or rather I would say questionably can lead to oral cancer. That's a conversation or a dialogue or a discussion that is still not settled. Anyway, we're going to look at all of those things and also some more on its management today. So if that's the topic you're interested in, you are at the right place. Let me welcome everybody, and let's move on to today's presentation. So we have with us, yes, we have with us Dr. Krishna Sundargiri. Now she's an oral pathologist from the RUHS College of Dental Sciences, Jaipur, India. But I have known her because she's actually very dynamic. She's been taking part in a number of our events. I have met her at conferences, and we sort of get on and meet on social media too. So I'm very happy, really very happy to have her here. And I can say this will be very interesting. And let me welcome her. Welcome, Krishna.
Thank you, ma'am. Thank you so much.
You are most welcome. Okay, we shall listen to the recording as usual and then come back for the discussion. Please put in your questions in the chat. Also, remember, as I have also put earlier, increase the quality of your video by going through the settings because you would need 360p and above to get a good image of all the text and to be able to read it, especially on a phone.
Hello, everyone. Before I start my webinar, I would like to declare that I have no conflicts of interest. On the onset, I would like to thank Dr. Bandana for this opportunity for me to speak on a topic of oral lichen planus. Uh, the first term that comes to my mind when I talk about oral lichen planus is the word idiopathic. What does idiopathic mean? It means arising spontaneously of an obscure or unknown cause. This word has been used, misused, and reused countless number of times. So, what is oral lichen planus? It is a chronic inflammatory oral mucosal disease. It is a T cell dysfunction induced local autoimmune disease in which corticosteroids are the drug of choice for treatment. The oral lichen planus manifests as various clinical forms in the oral cavity. Majority of these forms are asymptomatic and it gradually impedes the quality of life. Thus, oral lichen planus cannot be cured. In this webinar, I'll be going through the incidence, the etiology, the pathogenesis, the diagnosis and malignant potential of oral lichen planus, along with discussing the available treatment algorithms involving corticosteroids and few alternatives. Also, with the term integrative medicine in relation to this chronic oral autoimmune disease, involving also a note on the diet. If possible, is can we establish a diagnostic protocol as well as what I call as the OLP puzzle to understand that have we reached somewhere and the various research options on this topic. So let's embark on this odyssey. So when a case like this, like the case one, is an 80-year-old male patient with use of antihypertensive as well as anti-diabetic drugs. Patient complains of soreness of mouth as well as inability to eat even salty food. Often we come across a patient extreme end of the spectrum. This is a 24-year-old female patient with again inability to eat hot spicy food and complaining of a puritic papule on the dorsum of. When we come across such patients, we need to help them. So let's see what we can do, what we need to learn about oral lichen planus. The term lichen planus arises from the Greek word lichen and the Latin word planus, which means flat or even. It was first explained in 1869 by the English physician Erasmus Wilson because the skin lesions looked similar to the lichen growing on rock. Various forms of lichen planus have been described, such as the oral, cervical, the stomach, as well as some cutaneous forms as well. When we come to the prevalence of oral lichen planus, it frequently occurs in the middle-aged and elderly female patients. It roughly affects 1 to 2% of the entire population. When we come to the recent systematic review that was published regarding the prevalence of oral lichen planus in the entire world, there was subgroup analysis by a lower preference in prevalence of low oral lichen planus in the Asian countries compared to the non-Asian countries. The lowest prevalence was reported from a sample in India of 0.02%. But the incidence of oral lichen planus in Indian population was reported in 1986 as 2.6. And I don't think this has come down. This must be with what is fascinating is that every day we see ads like this, like 8 in 10 Indians may be multivitamin deficient, or India being the world's diabetic capital. All these are somewhere predisposing factors to oral lichen planus. So this is an area of study which we need to know the prevalence and incidence of oral lichen planus in India. There could be several reasons for these variations, but we need to search even more. Now, coming to the etiology, though the exact etiology of the disease is still unknown, a lot of factors are involved in it, such as genetic factors, immune system factors, as well as environmental factors such as various infections, such as hepatitis C. Psychological stress also plays a role in the development of oral lichen planus. The cofactors such as diabetes and trauma also have been added onto the causative factors. Now, in a recent study in 2019, the authors explored the role of psychological triggers in oral lichen planus and possible beneficial effects through meditation. Many oral lichen planus frequently display psychological distress, anxiety, depression, and disturbed sleep pattern. It is highly recommended that the clinician should be able to capture all these relevant factors, contributory factors, through proper assessment and clinical examinations. So it is really, really important to screen these grassroots level triggers, which would eventually lead to additional factors and eventually oral lichen planus. Actually, when you consider all this, it will enable the clinicians to holistically evaluate and treat the patients on predominant emotional factor and not solely on the pharmacological interventions. Now, coming to the pathogenesis, it is a cytotoxic CD8 plus T lymphocytes that are responsible for the apoptosis of keratinocytes in the basal cell layer. These lymphocytes are a major component of the subepithelial inflammatory infiltrate in the mucosal lamina propria. A host lot of factors are upregulated, such as the cyclooxygenase 2 or the COX2, or while there's a loss of CD40 and the E-cadherin molecules in the basal keratinocytes. The tissue destruction originates from the lymphocytic infiltrate and production of cytokines. They activate other molecules and other inflammatory molecules such as the CD4 plus, dendritic cells, and the natural killer cells also play a role in the development of oral lichen planus. But the antigen which triggers the onset is still unknown. And unfortunately, it has not been possible to identify a single etiological factor behind the oral lichen planus, especially to explain the bilateral and the symmetric nature of the clinical presentation. Here we discuss one more case where it was a 40-year-old male patient with presenting to us with a red and white bilateral skin oral lesions on both the right and left buccal mucosa. The presence of a red erosive lesion along with the white Wickham striae are indicative of a lichen planus, which is symptomatic. The patient was advised a lot of drugs here. He was given topical steroids and explained to him that he may experience both recurrence of these lesions and kept on follow. These patients do come regularly, but sometimes these people also react based on how they are treated symptomatically. Now, when we come across such patients, it's a challenge to diagnose oral lichen planus, particularly in the absence of classical reticular pattern on the oral mucosal surfaces. It was in 2016 that the American Academy of Oral and Maxillofacial Pathology described the clinical criteria along with the histopathological examinations for the diagnosis. The clinical criteria included white and red multifocal lesions with symmetric distribution, one or more of the following forms. They could be of reticular or papular, atrophic or erythematous, erosive ulcerative, plaque, and the bullous lesions that were localized outside the site of tobacco placement could be close or in contact with the dental restorations. The appearance of the lesions should not correlate with the start of a drug or the use of cinnamon containing products. While the histopathological examination indicates band or patchy, almost lymphocytic infiltrate in the lamina propria, limited to the epithelial lamina propria interface, with basal cell liquefactive hydrophic degeneration, lymphocytic exocytosis without any epithelial dysplasia. Now, when we come to a clear, precise final diagnosis, it is necessary to go through a thorough history and clinical features of the lesion to be correlated with some testing. That is the histopathological examination, a direct immunofluorescence test, or indirect immunofluorescence test, along with cutaneous patch testing. The characteristic direct immunofluorescence finding for the oral lichen planus lesion is a deposit of fibrinogen in a shaggy pattern at the basement membrane zone in the absence of immunoglobulin and complement. It is often necessary to differentiate oral lichen planus from mucous membrane pemphigoid and pemphigus vulgaris. So sometimes the indirect immunofluorescence in oral lichen planus is negative. Cutaneous patch testing also should be performed to rule out type 4 allergic reactions to the dental reaction. So, a whole lot of oral lichenoid reactions also are described in relation to, such as the oral lichenoid drug reaction, oral lichenoid contact hypersensitivity reaction, chronic graft versus host disease, lichen planus pemphigoids, then chronic ulcerative stomatitis, and lupus erythematosus. While histopathology is a valuable tool when lichenoid reactions have to be differentiated or discriminated from other mucosal lesions. Guidelines on the necessity of biopsy to arrive at an accurate diagnosis of oral lichen planus have not been universally approved, but most clinicians accept the need for biopsies when the disease severity is moderate or severe or the diagnosis is uncertain. When we come to the malignant transformation of oral lichen planus, both oral lichen planus and oral lichenoid reactions have been included in the 2022 WHO classification of oral potentially malignant disorders. The status of lichen planus as potentially malignant is generally accepted, but the degree of risk remains a matter of controversy. The lack of definitive clinical and histological diagnostic criteria, overlap in histological features between lichen planus and dysplasia confound the analysis. The malignant transformation rate has been reported as 1.14% for oral lichen planus, while the malignant transformation risk is higher in atrophic or the erosive lesions, with tongue carrying the highest risk as a site. The signs which include for malignant transformation should include non-lining ulceration, surface structure changes, and induration that require urgent referral to secondary care. It has been long recognized that many oral epithelial dysplasias have a lichenoid immune response composed of a lymphohistiocytic band-like infiltrate with T cell mediated epithelial cell destruction. The histopathological finding should not be confused with oral lichen planus, in which the presence of dysplasia is an exclusion criteria. So there's lots of confusion, lot of discussions going on the inclusion of epithelial lichen planus as a potentially malignant disorder, as well as whether there's a malignant transformation rate seen in the lesions. Thus, it is definitely a chronic disorder which patients have to. We come to the algorithm for the management of oral lichen planus. The management of oral lichen planus is basically aimed at reducing the symptoms healing the ulcerated areas, and prolonging symptom-free periods. So it is basically based on history, physical examination, and histopathology. The mild asymptomatic disease are normally not given a medical line of treatment. Our patients are normally advised for a follow-up. The mild and the moderate symptomatic diseases are treated by corticosteroids. The topical corticosteroid, if is applied for the mild symptomatic diseases. If no response is applied, then a topical calcineurin inhibitor is advised. Now, both drugs have their advantages and disadvantages. When we come to the moderate symptomatic disease, the systemic corticosteroids normally elicit a response, and if response elicited, oral retinoid to remove the whitish patch can be used. Severe symptomatic disease always needs our attention, and systemic corticosteroids are also added, given along with immunosuppressants such as methotrexates, mycophenolates, and tacrolimus. Often, biologicals such as tumor necrosis factor alpha inhibitors also have been used. Now, to summarize the treatment options, the oral lichen planus treatment options can be pharmacological, non-pharmacological, and natural. The pharmacological aspect also includes the use of antifungals, which come along as a uh, counter for the extensive use of corticosteroids, either topical or systemic agents. Certain immunosuppressants as cyclosporin, tacrolimus also have been used. Certain systemic drugs such as retinoids, dapsone, thalidomide are also being used. Non-pharmacological or the surgical methods used include PUVA, the photodynamic therapy, and a low-level laser therapy. Natural agents such as lycopene, curcumin, aloe vera, and green tea also have been explored, and huge results are coming out for these. We will talk about them in the future slides. Now, when we come to corticosteroids, the decision whether to prescribe the local or systemic therapy of corticosteroids depends on the disease severity, the extent of pain, and the individual patient's need and ability to cope up. So there are three forms in which the corticosteroids can be administered. They are topical, intralesional, and systemic. Now, basically, corticosteroids act by the way of anti-inflammatory action and an immunosuppressive action of the immune cells that lead to the pathogenesis of oral lichen planus. There's a whole lot of topical steroids which are used. They can be medium and high potency ointments or gels for localized lesions, or as used as mouthwashes where 5 mg tablet is dissolved in water or in a which can be used as a mouth rinse. Now, or a spray for widespread lesions. Often sprays are also used as a nasal spray also to give a effective treatment of the oral lichen planus. Intra or perilesional injections, when needed, are also indicated in the case of injecting into the lesion. The triamcinolone acetonide is diluted with 0.5 ml saline or lidocaine 2% and then injected into the lesion. The drawbacks of this intralesional corticosteroid therapy are atrophy of the tissue, secondary candidiasis, and difficulty to deposit sufficient quantity into the gingival lesions. Most of the time, antifungals are also prescribed concomitantly. Apply the drug 2 or 3 times a day during the 3-week period, followed by tapering dosage until the dosage of 2 to 3 times a week is reached. When we come to the application of systemic corticosteroids, they're the first line of treatment only for severe or widespread oral lichen planus, or where patients are severely symptomatic and are unable to even eat or chew, and they disrupts his daily lifestyle. For lichen planus or for the lichen planus involving other body sites that are recalcitrant to the topical therapies. A dose of 1 milligram per kg daily for 7 days is followed by a reduction or a reducing dose of 10 mg per the subsequent days till the next week. Now, when we come to the surgical or the non-pharmacological line of therapy, surgical excision, cryotherapy, CO2 laser have been used in differentially in the treatment of oral lichen planus. Surgery is extremely reserved to remove the high-risk dysplastic areas. Now, a special case mentioned about the gingival lesions. The gingival lesions are normally highlighted to optimize the dental hygiene. To maintain a good oral hygiene will be the prerequisite for a person suffering from gingival oral lichen planus. They need to be remaining symptomatic lesions of this need to be treated with steroids, which can be used in a occlusive splint or a medication tray. These trays can be custom-made trays, which are used for 10 minutes by applying the medication at the site and can be applied twice a day. Now, when we come to our fourth case, where it was a 60-year-old female patient with severe red and white lesions and erosive form of oral lichen planus was found. And here we can see how it is affecting her. Even her oral hygiene is poor. So these patients need our attention. They need our care. They need our advices. And we can actually do lots of wonders in their life by giving them the proper therapy. But sometimes systemic or corticosteroids or the first line of drugs are not effective. So there comes our alternative supplements. Two alternative supplements which come to fore when we are talking about oral lichen planus is aloe vera, and the second one is curcumin or turmeric. Aloe vera gel has been suggested to treat oral lichen planus, in which the oral lichen planus has been more effectively treated than the topical corticosteroid for reducing a symptom over a period of 8 weeks of treatment. The aloe vera mouthwash also seems to help to heal oral lichen planus. Now, when we come to the second curcumin, which is an potent antioxidant, anti-inflammatory, anti-mutagenic, antimicrobial, and anti-cancer properties. The turmeric ointment has been seen to reduce the inflammatory and modulate the immune system to improve the appearance and decrease the discomfort of oral lichen planus. These two, yes, are naturally derived products which need to be explored or and can be readily acceptable by the patient, except that turmeric, yes, patients do complain of some staining and not able to use during their working hours or morning hours. So there are few, if anything new when we suggest to patient, maybe the acceptance of alternative methods can be much more higher than compared to the traditional forms. Now, when we come to all these alternative methods, a functional integrative medicine approach to lichen planus uncovers contributing factors, addresses them using diet, lifestyle, and food supplementation. So basically, it is a patient-centric, home-based continuum of self-care for various forms of chronic diseases. Basically, allopathy, Ayurveda, diet and nutrition, along with de-stressing yoga, are integrated into the medicine along with patient education and patient participation for a successful treatment of the chronic disease. So there are lots of mind-body practices which are also advised to manage stress and also are helpful in healing the chronic skin and mucosal diseases and improving the quality of life. So, the second part of the complementary and integrative medicine for lichen planus includes suggestion of an oatmeal bath. Basically, oatmeal can be soothing to the skin lesions and the mucosal lesions when these which occur in the lichen planus. So the in which the grinding oatmeal into a powder and it is added to a water where you can soak your skin or apply it to the affected area for 10 minutes to get a resolution of the lesion. Also, homeopathy is also can be explored as a complementary healing modality that uses small amounts of substances to treat the disease. It's often these therapies are individualized into taking into account many factors of the individual, such as personality, pathology, and lifestyle preferences. And definitely, yes, stress management. The entire story of lichen planus evolves eventually maybe on stress, which needs to be controlled. Apart from all these things, lots of health groups and all are talking about nutrition considerations during oral lichen planus. Nutrition plays a key role in the development of dysregulation of immune system. So you may need to know which food triggers in our diet by one, so that some can be avoided and some can be increased in diet. Often, patients or a person who is suffering from oral lichen planus is asked to avoid spicy or acidic food or hot drinks laced with peppers or caffeine, citrus fruits, alcohol, and sometimes even tomatoes. Definitely, it is much more advised to do this. And a person can be advised to take vitamin A rich or folate rich foods and sometimes avoid low sugar, to take low sugar fruits or non-starchy vegetables and to avoid processed uh, wheat to avoid the candida that can be detected in oral lichen planus patients. So yes, food plays a major role in uh, determining whether we can help these patients in controlling their disease. Definitely, and not only that, a maintenance of good oral hygiene also plays an important role for healing of the erosive oral lichen planus. And as I said, we need to avoid hot, salty, acidic, or spicy foods, as well as uh, men- work on maintaining a regular healthy lifestyle. And at this point, I would like to say that patients need to avoid oral risk factors such as betel quid chewing, cigarette smoking, alcohol drinking, in all these conditions. We should always keep this in mind that the skin lesions, compared to the lichen plants of skin, the oral lesions may persist for many years. And often, compared to the cutaneous form, the oral lichen planus does not resolve spontaneously, and that is why maybe skin and oral lichen planus have a different mechanism driving the uh, disease process. At this point, we should also remember that there are a lot of systematic reviews dealing about the existing therapeutic interventions. And when we come to the systematic reviews, they help us to evaluate what is the available treatment options. A recent study by Sangupta N in 2024 talks about the available treatment options in such as corticosteroids, calcineurin inhibitors, aloe vera, curcumin, hyaluronic acid ointment, thylamides, lasers, cryotherapy, and the photodynamic therapy. So, what happens is there's no indisputable evidence to support the superiority of a therapeutic measure in terms of its efficacy in treating oral lichen planus. Thus, it is establishing a rational treatment plan for oral lichen planus may be the need of the hour, and topical corticosteroids are the first line of treatment in the management of symptomatic oral lichen planus. All the existing therapeutic interventions may are ineffective in treating the symptomatic oral lichen planus. So, more studies, more randomized controlled trials are necessary to investigate and provide confirmatory evidence regarding the potentials of various therapeutic agents in managing the symptomatic oral lichen planus. So when we have heard so much, when we have read all about all this, it what happens when such a patient comes to you? So we I would like to suggest a diagnostic protocol for oral lichen planus, which could include a complete blood count, complete liver profile, including the serum transaminases, total bilirubin, which also could include and count of antibodies to hepatitis B, C, and also the surface antigens. A random blood sugar level could also be assessed along with vitamin B12 and various thyroid tests. Always remember, as a clinical point of view or a clinician, the photographic records also will play a major role uh, to assess the determination of any response to therapy and can also become a part of the evidence of clinical outcomes. At this point, I would say the confidence of the clinician or the attending physician also matters. The patient should be instructed how to self-monitor the oral cavity, since it is one of the most accessible parts of the oral body of the body that needs to be explained to the patient to how to self-monitor and self-examine himself. We can say that the reticular oral lichen planus with no erythema or ulceration can be monitored every 6 months. So it depends upon the type of lichen planus that patient is suffering from. The follow-up periods also can be subsequently. For reticular oral lichen planus, it could be 6 months. But for the erosive forms, you need to have a follow-up of at least after 21 days to 1 month, so that we can actually see how well the patient is responding to our systemic therapy. So, with all this, what comes to us is for decades, efforts have been exerted to piece the available information together and organize it. Now, what has happened when so much of information is there, the pathogenesis is understandable. But unfortunately, this oral lichen planus puzzle actually starts at the unknown etiology. It is still not understood about the various complicated and branched pathogenesis. We still don't know which pathogen or what is the particular antigens that triggers this disease. There's a lack of effective cure, as well as we still don't know whether this can be treated as a potentially malignant lesion. So there are lots of missing pieces around. Somewhere we have to play a role to fit or find these missing pieces. Now, what are the various research areas that need to be explored? So we need more research. We need more patients, to find the exact cure. Here, I would add two more P's to the lichen planus, that is precision and personalized medicine. So every patient is not the same. Every patient needs a thorough history. He needs personalized care, and the treatment has to be personalized to that particular patient's requirement. The second point or a research area is how do genetics has a role in determining the type and site of OLP? How can one say that if there's a family history of genetics, will that sibling or your progeny is going to suffer from oral lichen planus or not? As oral pathologists, we could play a major role in the various diagnostic methods via saliva or via oral microbiome analysis, were showing more susceptibility to suffering from this disease. Studies on various alternative treatment methods, modes of delivery, efficacy. At this point, I would like to highlight that a multidisciplinary approach to treat even oral lichen planus, be in collaboration with our oral surgeons, oral diagnosticians, oral medicine people, could maybe catch hold of this disease, which none of us know. A lot of work and clinical trials is being done on anti-interleukin 17, anti-interleukin 12 and 23, which can be explored. Finally, it is much better to do a prevention rather than finding the cure. So if we can work on how to prevent the occurrence of oral lichen planus, maybe we'll be able to catch hold of the puzzle. So uh, before I end, I would say let's solve the problems together, and a multidisciplinary approach would always be a go-to with this approach. Thank you.
Thank you. That was a wonderful lecture. Very, very well organized and very well discussed. And we have questions. So we'll
Yes, ma'am.
jump right in. Okay, let me see. I think the first one is a comment by Dr. Nasser. I just want to bring up that rarely you will see IgG and fibrinogen in lichen planus pemphigoid, but you should also remotely think of Ellie,
Ellie.
lupus. Yeah.
Yes, ma'am. I think Sir rightly pointed out, Dr. Nazir, that it is IgM also which we see in the lichen planus cases. And definitely systemic lupus erythematosus in both forms, the systemic form and the discoid form, are very much in the differential diagnosis for lichen planus also. I would agree with Sir. That is true.
Okay. The next one is from Dr. Chaitanya. So, what he is commenting the forever question. Has anyone ever come across any case of malignant lichen planus without any habit of chewing tobacco?
Um,
So,
Hi, sir. And uh, ma'am, I think I have not come across. Recently, we have come across a case. He had previous history of tobacco use, and he was hepatitis B positive patient. And then we diagnosed him as suffering from lichen planus. We got the biopsy done, and it turned out as malignancy. So biopsy is important. Now again, highlighting what sir said, ki habit history will give us idea for malignant potential. We cannot rule out in this case that he will have to just go on follow up. You have to get the biopsy done. Now again, highlighting the histopathologist here.
True. Okay, we have another from Dr. Nasser. His own experience. Adding yogurt with culture to the diet reduces the risk incidence of candida. It worked great for me. So he has experienced it and it works.
Ma'am, here I have not taken any word, but if you use desi ghee, that is a very typical word which I am using. The ghee that is not packaged, or the one which we take from the local cow, it also is very, very effective, like yogurt, same way.
Right. So, okay. I think even outside India, but of course they would have to make it at home. But there are stores, almost Indian stores everywhere that sell ghee. So that should be no problem getting it, at least the store made one.
Yes, ma'am.
Okay, that is from Dental Wellness. How do we relate blood investigations with OLP as far as diagnosis and treatment is concerned?
Ma'am, I think I've been reading a lot of literature. A lot of literature is there about the. It's like that's why I thought that we should put a protocol for diagnosis also. In general, the susceptibility for developing oral ulcers actually becomes very important when you are already in a deficiency state. So one of the forms of lichen planus is erosive form. So when you are able to put forward that your body is able to cope up with the lack of any nutrition, you are ruling out other diseases actually. By we have a lot of studies saying that iron deficiency leads to folic acid and vitamin B12. So they're all empirically used to treat the symptoms actually at present, and make the oral cavity self-sustaining, self-healing also. I think it plays a major role there. So if we have an idea that a simple blood test can tell us whether he's susceptible or not, maybe we can prevent more uh, occurrence of disease. Prevention again plays a role actually. Cure definitely we are giving symptomatically.
That's true.
There, so
Basically, we
blood.
are doing management. This is one of those things where we just manage. But
Yes,
even
ma'am.
that is important.
Yes,
For
yes, ma'am.
someone who is symptomatic, getting rid of the symptoms is the most important part. Okay, and yes, Professor Hiller has agreed with Professor Nasser that yogurt works. Okay, he also says nice and concise lecture. Then we
Thank you.
have a comment from Dr. Arushi. Okay, can you sum up the treatment? What we can use at our clinical level? What medicines can dentists prescribe or should direct to dermatologists?
Ma'am, we should be confident to deal with these patients because our confidence affects the patient's trust in you. And I think to treat a chronic disease, it is the trust factor. People will come back to you. First thing that I would suggest is if we are able to diagnose that this is not a viral infection and this is something which I am related to chronic. So our history becomes important. Once history we are clear, yes, this is a condition which is going to happen, we explain the patient that it may reoccur, and then gain his confidence and start prescribing whether it is an erosive form. We can start with topical form, topical corticosteroids. Often I would prescribe a 3-week dosage, and a patient, I have this habit of telling the patient based on the local language. So I say that take a matar ka dana jitna steroid applied, and before applying I always ask the patient to have a mouth rinse before applying his steroid and use clean hands. These are small things when you pinpoint to the patient, and he will have good effect of your drug. If you have unclean hands and you apply into your mouth, you're not going to, the drug is not going to be effective. So I would suggest is that we can start with topical form, and even if you are advising blood test, you can actually put him on folic and B12. And for females especially, we have a lot of iron deficiency which nobody agrees. So maybe treating with iron, there could be wonders to the treatment of lichen planus. I really feel that we need to treat the iron deficiency. It is nobody recognizes that we are iron deficient. So
Actually, iron deficiency is very high in India. I think
yes, ma'am,
in a
it
number of
is.
countries, but also very much in India. And surprisingly, it's not entirely poverty driven. It's mostly due to bad nutrition, because a
Yes, ma'am.
lot of youngsters who have no reason. I mean, they are not anywhere within the poverty spectrum, but because of their diet, they are actually deficient.
Yes,
You are totally right. Yes.
yes, ma'am.
So
Ma'am,
let's see. Yeah, I'm just getting to. There
ma'am, we will
is,
load.
yes. So there is, in terms of understanding lichen planus, I have brought in the concept of psychoneuroimmunology.
True, true, ma'am.
Very
Very true,
good.
sir. Dr. Jose, yes.
Right. We have, oh, we have a patient with us. Okay, that's rare. Okay. Suffer from OLP for the last 7 months, and for me, stress plays a major role in this disease. Yes.
Ma'am, I would agree there's nothing like stress and correlating to skin disorders or even oral lichen planus. Maybe we can connect and we can help you out if you're from somewhere nearby. Maybe we can help by connecting. Uh,
Yes.
you could use my Insta handle or something like that, or ma'am's handle, and can connect to us. We can help you out, definitely.
Yes. But as a whole, I have to put in that disclaimer that please don't directly take information from here and try to use it, because that's really not the purpose. Although we would be happy to help, yes. And we do hope you get well soon.
Yes, ma'am.
Yes. Okay, we have another one. So, if a person is diabetic, then corticosteroid may be contraindicated, but can we prescribe triamcinolone ointment? And what is best medicine for diabetic persons?
Ma'am, I would not go by the textbook way. Yes, it is contraindicated, but you don't. If you, systemic corticosteroids are majorly contraindicated, there's a big no-no. But I feel if the topical form, when used properly with proper instruction to the patient, is be very very effective. As I said, I do regularly advise topical form, and you can always tell the patient to have a mouth rinse, okay, before you apply your corticosteroid, and you will always ask him to spit whatever the salivation has occurred because of application of the medication. In that way you're also helping him not develop candidiasis, which is the susceptibility factor in diabetic. So it is more of a, clinical point, and your experience will tell you that yes, we can give the topical form, and it advise him particularly that he will do a mouthwash, clean hands, and he has to taper the dose also. That what patients do is that instantly they have relief, they stop using the tube. It's very very common, they disuse the drug, and this drug is not to be disused immediately. You have to taper the dose. So again, here the clinician or the doctor has a major role to convince the patient to follow your regime. That is most important. So a diabetic can be managed, and alternative methods are there, so many are coming up now. Maybe you can advise aloe vera to him. You can, if he's okay with curcumin, you can advise him that also. Symptomatically you can give him a lot of relief.
Yes. Very well answered, and a very good question too. Okay, so we have another one from Professor Hiller. Is my anatomical pathology laboratory has ditched fibrinogen from the direct immunofluorescence immunopanel. He has to refer the case to the academic laboratories who still keep it in the panel.
Agreed, sir, agreed.
Okay, Dr. Nasser says very nice lecture, and okay, so we don't need to worry. That is Dr. Siva. Okay. Actually, I thought she mentioned somewhere that she is a doctor. Where did I not see
Ma'am,
that?
it is, I would hats off to say that they are, you're able to put forward your messages in a public platform.
Yes.
Accepting that you have stress and you have a disease is even It's a great job that you have done, I
It's a
think.
great job. Yes, absolutely, definitely. So okay, and there's experience that is very useful also. Not stress, and when I'm stressed, it increases. So I guess that psychological part tension is the problem with so many things.
Yes, ma'am.
Hour to hour change. Wow, that's interesting. Okay. Dr. Dipanjali says, very interesting lecture. And then she says, is oil pulling effective?
Ma'am, again, now, what type of oil are we using? Are we using any oil that is anything based on hydrocarbons or petroleum based? It is going to be, we have to use coconut oil. Maybe Dr. Dipanjali can do research on this. She could use a cohort using oil pulling by coconut oil. I would encourage her to do that. It could be effective, ma'am. It again has by this physical barrier that it creates on the mucosa. And homeopathy vouches the use of coconut oil. So Ayurveda vouches it. So you can,
Yes,
what suits you?
definitely something you can try and test. Nothing like
Yes.
getting, just recently we had ethnodentistry lecture,
Yes.
which basically
Yes.
was focused on the same thing, picking up
Yes.
all our ethnic drugs and
Practice.
whatever herbs and things and testing them to
Testing
establish
them.
them. Yes. Okay. And here we have, where am I in this list? Okay. Dr. Madhura says, very informative session. You're welcome. Okay. Professor Hiller says, the DIF for fibrinogen does not correlate with the past enhancement of the lamina propria in LP.
Uh, yes, sir. What I have noticed is that most of our oral lichen planus biopsies passes the easiest for us to do see, but duplication of the basement membrane also may be a feature which never nobody discusses. The PAS enhancement of lamina dura could be some collagen or some part of the basement membrane which is secreted as a remnant or something like that, which the PAS is picking up. We'll keep, sir. We need to research. Now I have got more ideas with your suggestions. Thank you.
Yes. So another one is about serum iron levels are important overall in the mucosal health. I guess because the whole renewal of the cells gets
Affected.
affected. Dr. Chaitanya has a comment. One should be cautious about treating lichen planus cases with laser, more so if the patient has tobacco chewing habits. You may cause more damage to the epithelium and may lead to malignancy.
Agree, sir. That's true. And again, hi, sir.
Okay, and Dr. Vivek, yes. So, very informative lecture, throwing light on different treatment avenues, especially looking forward to the iron deficiency part. Thank you. Yes. And I had read it ahead. Yes, she is Dr. Sriva. Yes. Okay. Still, very nice of you to have searched to share your own experiences. That really makes a difference. And Dr. Nasser, interesting. Usually don't do pass, but great to know. Okay, right. Also very interesting here. Iron levels may be low because of loss of iron or lack of absorption of iron due to subclinical gastric IBD. Yes. If you want to comment on anything, please jump
Yes, ma'am.
in. I get the sense that this is just a continuing statement, so I'm just going with it. Yes, subclinical gastritis being high in stressed patients and GERD and GOD is an important symptom. So it's a sort of a loop, I guess.
Ma'am,
Everything's finally works together.
to support him, actually in India, we never talk about H. pylori gastritis. I mean, we don't even speak about it. I think it is, again, we need to now be aware of it. As Indians, we eat so much of hot, spicy food, so much of outside food is being consumed. We don't know what are the parameters that are being considered. Ma'am, just an area of research. Maybe somebody could take up H. pylori also, uh,
It's
Helicobacter
very true. In
pylori.
fact, I have found quite a few of people I know who have had to go on the treatment because of the H. pylori, because gastritis was found, which then led to the whole testing. And okay, the dental wellness also says great lecture. The Siva has answered Dr. Dipanjali. I love this when there is interaction between the audience also. Okay, yes, cold pressed coconut oil helps and soothes the lichens, the lesions for me. Yeah, wonderful. Okay. And we have before application of topical steroids or other agents, I ask the patients to rinse first with betadine, then rinse with water and spit out saliva as much as possible before applying the drugs. This is also a good idea, yes.
Yes, ma'am. It's easily available than the normal mouth rinses.
Especially post COVID. Every
Yes, ma'am.
household has sufficient quantums of betadine.
True, ma'am.
Okay, we
True.
also have Dr. Shelley with us. All right, so do you advise biopsy for all clinically diagnosed OLP lesions?
Ma'am, it's a very personal question, Dr. Shelley. Thank you for this question. I would advise yes, but I have to be more sensible and listen to my diagnosticians, that the oral medicine people. They say ki, we will not biopsy every patient. So when you know the patient is not symptomatic, or he just has a white lines and some pigmentation, you do not biopsy. We can keep them on medical or on follow up. Only the ones which are suspicious or not getting the symptoms are not getting relieved, I think we would go for a biopsy for that. As a pathologist, I'm happy with the more the biopsies, more the happy the pathologist is. But the medicine people are very, very adamant. We will not biopsy all. We will
Yes,
only take care of the symptomatic. So seeing the patient load and the patient awareness. Is the patient wanting for biopsy? Yes, definitely we should. And if the patient is reluctant and the patient is not symptomatic, I think we don't need to. So I have to keep the pathologist out of this question right now.
yes, of course. So Professor Hiller says there's a concept of pulse treatment with steroids, very much so. And Dr. Rajesh says mostly I will confuse an oral lichen planus and leukoplakia. So best way to differentiate between these two oral lesions. What is the difference in treatment protocol and antioxidant tablet helpful? But what is in which one? I guess is what
I
is
think
supposed to be.
they're two different, doctor. They're two different conditions. I mean, unfortunately, if we are from our part of the country, part of the world, yes, these two can be confused because they can be seen very, very frequently. But lichen planus will always give you a history of occurring and getting healed, occurring and getting healed. Leukoplakia is nothing which is never going to come and go away. It will be a white patch. Either it is increasing or increasing in thickness, unless you are using some drugs to reduce, or you're actually physically removing the white patch. And again, in parts of the Southeast Asia or India, we have tobacco as the causative factor for leukoplakia. In most of these habits. But again, ma'am, I would highlight here people who even eat flavored tobacco or even supari. Uh, I find that the supari, the flavoring agent, also can lead to a lichenoid-like reaction. If especially if that person is susceptible. So history becomes very important, not only clinical examination. And general dentists are very scared to look into the soft parts. So maybe you can take help of a expert. Could be a postgraduate in medicine or pathology, or even surgeons are quite good at diagnosing leukoplakia from lichen planus.
It's true. Dr. Vandana also says very nice presentation. And interestingly, we have the next question that sort of links back to this. Dr. Madhura, she says, please comment on concomitant lesions of lichen planus and leukoplakia or OSMF.
Ma'am, they could be. They could be a link. They could be a link. We actually have to explore this link, especially the proliferative varicose leukoplakia and the forms of lichen planus where everything is mixed up with the habit of tobacco. That's, I think Chaitanya sir has been highlighting that. Have we seen any malignant transformation of lichen planus without the use of tobacco? I think we haven't. So, awareness of the diagnostician of the clinician and reliability of the biopsy. Here now, these are the cases which actually have to go for biopsy. So, biopsy could give you a real good indication that if we see a band of infiltrate in the just in the juxtaepithelial area, so we will have to go for lichen planus and treat accordingly, because now steroids cannot be rampantly used to treat lichen leukoplakia. It's like you have to discontinue the habit. Removal of the stimulus has to be done. So, Madhura ma'am, I would suggest that we could go for biopsy. And submucous fibrous patients have their typical experiences, but submucous fibrosis patient who is susceptible to this Eracanet use may develop some form of lichenoid reaction. So that may not be a bilateral, only where he's placing his stub or the quid is maybe he develops a lichenoid like reaction. So we have to rule out. We have to give a thorough examination and clinical as well as histopathological. I hope that answers some part of the.
Yes, very true. I also think clinically, lichen planus tends to have its, you know, what is it, bilateral
Ma'am, it gives hints.
presentation.
It gives
I
hints.
just forgot the word. Okay.
Bilaterally symmetrical, ma'am.
Yes, that's what I wanted. Okay. Yes, that sort of hint may be there, hopefully. Okay, Dr. Rajesh has continued with that question saying, what is the dose for multivitamin tablet? How many days patients should take this medicine?
Uh, what we need to understand is vitamin B12 is the multivitamin that we would advise. It is a water soluble vitamin. So when we always start multivitamin, we always give a loading dose. We have to we're assuming that the body is not having sufficient multivitamin. Maybe that's the reaction. So we will put it to like maybe twice daily for about a month till you get some resolution of the symptoms, and then you could come to one tablet, or you can discontinue and maybe restart after a follow up of 3 months. So multivitamins and water soluble multivitamins can be given. The body takes whatever it wants and then rest is excreted out. So don't worry. But for a loading dose, especially when the patient has come to you, you can give him twice in a day. He can take for about a month. That there's nothing to worry that you're overdosing the patient there. It only has to, like, he has to think about his finances.
That's true. Okay. Dr. Siva is saying, I read an article about the role of apremilast in treating OLP, both topical and systemic. I have no clue what that is.
Ma'am,
Have you
we'll
heard?
have to Google it. I don't want to do it right now, but Dr. Shiva, I will like to get in contact with you, definitely.
Okay. So we have, again, I don't know whether a doctor or a patient. My daughter, who is 6 year old, has OLP. It has been a year already. Got her blood test and ANA test done, to which is all normal and negative. Yes, further
Ma'am, we can
tests
actually
and
help you here. Actually, we understand if a young child gets to just find out what is she wearing. I mean, sometimes I feel even clothes could be an irritation to this one. That could be a trigger of having ulcers in the mouth. A deficiency state. Often these the kid 6 year olds, 7 year olds are very finicky eaters. So maybe zinc or some nutritional supplement could help you there. And when she's having the symptoms, maybe a softer diet, a less salty or less spicy diet could give her. You can give her some curd, as we had suggestion above.
right. Dr. Hiller has explained the whole pulse treatment with high doses in at least three recurrent episodes of about 3 weeks, with a week's rest in between the episodes. Evaluate the status after 1 week of rest, and there's a follow up to that. This is based on the concept that lymphocytes are being desensitized further with the steroid. Other agent application.
I think, ma'am, the name itself says pulse.
Yes. So, and this is the exact protocol. So, thank you, sir, for sharing that. And Dr. Vivek, what care and important points should be kept in mind before taking a biopsy of an OLP case?
Uh, Ma'am, I would first go for the medical line of treatment. I would not immediately suggest a biopsy for every patient, but we are in a world where the patient knows how to do a Google search. So we have to be very, very careful when if the patient is insisting that I want a biopsy. We had a patient who was on long term follow up and said, "No, I want the biopsy done." Then we did it. So for but when we think as a benefit of patient, biopsy itself is making an wound there. So you have to be careful. Let's do the medical line of treatment as a first treatment of choice. Look for the symptoms to come down, and even if they reoccur with your this one treatment, maybe we could go for an biopsy, because biopsy itself is a wound which has to heal there. So you are, instead of treating, you're patient for more acute discomfort to the patient. That we have to keep in mind.
Okay, we will take the last few because I think we are going well over time. Dr. Vandana says she has come across cases of concomitant lesions, so I guess with leukoplakia and with OSMF. Dr. Rajesh says antioxidant tablets like weak core, cold dose, and duration. And he also says thank you for answering all the questions. Right.
Ma'am, we
Okay.
haven't missed, I suppose, anything. We have been.
No, so far we haven't missed anything. We have sort of covered everything. And Professor Hiller, yes. Regarding vitamin levels, do not forget the benefits of vitamin D at the right levels. That's more than
Yes.
35 to 5 nanogram. Yes. Yes, many people are actually short of vitamin D. Surprisingly, even in a country like India where there is so much of sun.
Ma'am, I think I recently read that we are actually deficient of the enzyme 5-deoxy enzyme, which converts the vitamin D to an active form of vitamin D. So, actually, as Indians, the sunlight has nothing to do with our vitamin deficiency. We need to eat our
Yeah.
sachet. All of us need
Yeah.
to.
That's what. Very
So,
true.
this
And a good point.
it is there, ma'am. We need to know that.
To know that, yes. Okay. Also, zinc loading is very recommended. Yes, thank you. And Dr. Arushi says thank you to Dr. Joss for interesting and important input. And Dr. Joss said there's a flip side of not biopsying. That's also true.
True.
And Dr. Varis has continued with that, saying the role of biopsy is so contentious. While some we should, others say we should not. We have to be clear on this. I guess it's really case to case in a lot of ways.
Yes, ma'am. It is. It is.
Yeah. For some things, it's very clear, very difficult to have a clear guideline. Eventually, it comes down to that personal decision of that doctor and what is their experience.
So
At
we
least
have a
today, it's very easy to get expert opinion and help from others around the world.
yes, ma'am. It was very nice to see, sir, and
Yes.
helping out. And actually, he's whatever I am answering, like the 6-year-old patient. We said we
Hmm.
need to worry about the zinc. So, sir
Yes.
just said yes.
Yes. Correct. But there are some people who are always there and always adding to the discussion. There is Professor Nasir and there is Professor Hiller. Sorry, and they really add to the whole discussion
They
always.
they do, ma'am. They do.
I mean, unless they are otherwise involved somewhere, they do attend. And it's amazing to me considering they must be already so well informed and still they turn up religiously to interact, to learn, to add. Okay. So before prolonged treatment with steroids, one should make sure that there is no dysplasia in the biopsied lesions, the theoretical risk being that cancer can be triggered.
Yes.
Yes. Right. Okay, I think we've got all the comments and all the questions. And now we'll just take a moment, everybody, because I have news for you all and messages for you all. We will come back. Dr. Krishna is going to be still with us. So if you have something last minute, we will again deal with it afterwards. Right. So, first, I have to share with you all. Yes, I am supposed to share and welcome our new members. So, let me. Right. So we have a new member in our community on YouTube, and that is Dr. Soundarya Srinivasan. Thank you so much for joining us. And for everyone who wants to know, besides the many perks and things that you get, which you can check all the details by clicking on the join button below, but you also get to see this. The atlas of clinical pathological video atlas of oral and maxillofacial diseases, which is being made so that each lesion can be searched, and this will become a very helpful atlas. I am asking for the contributions so that will help to the continual making of the atlas. So if you would like to join and if you would like to help, please click the join button which is below and check out and see if you would like to join with any of it. We will definitely appreciate it. And of course, as it is, everything stays the same. The rest of the programs will stay as wonderful and as free as ever. So, right, that is one thing. And then the next thing is big news is that our conference is back. And mm, what happened? Sorry, I'm on the last slide instead of the first. Okay. So the International Oral Diseases Case Presentation Conference 2024 is back. The date I had already mentioned was the May 3rd to 5th. As the last time, it's a completely virtual event on a very interesting platform called VFairs. You will have amazing interactions, amazing sessions, networking, and it's the whole thing. It's difficult to explain, but please check out on the website. There is a link which also says to the site, which is VFairs, and you can see what an attendee experience could be. You can scan this QR to go to the registration. You can also just go to the website at oralpathology360.com, and on the homepage itself you will find the link. Now, of course, this is okay, right. So you may wonder, why should you attend? There are, of course, keynotes and guest lectures like last time. There are case presentations by participants and then followed by expert commentary. For this, the abstract submission will be shortly available, open. Then there are discussions, networking, technology update, and also this is a conference that will be live or will be on for 48 hours. It will be live for 24 hours with 3 hour or 4 hour alternating sessions so that people from all around the world can watch it live. And in between, we have replays and, of course, replay of the whole conference for 15 days afterwards. And the proceedings abstract will be a book, an ebook with an ISBN, so you get that registered too. As to who it is for, well, it is oral pathologists, naturally, oral medicine, radiology, anyone who has an interest in head and neck diseases, oral surgeons, dentists, and researchers, students, really anyone who has an interest with anything in the head and neck section would be welcome and should take part. As the last time, it is a very multi-organization event. We have multitude of partners from organizations who are knowledge partners and institutions who are academic partners, and everybody's help will see that it is a really grand occasion, scientific feast, I would say. And these are the registration fees. They are separate, of course, for India and for international, simply because that's the requirement. And at the moment, there is a 15% off till the 10th of March. So if you hurry, you will get the 10%, 15% off. And with that, yes, please do join us, do register, and also share it with others. So let's come back here and see what's happening. Right, I actually brought you directly to the certificate page. But I think Professor Hilla has something to say.
About Intralesional.
something, something. Let me see. At the conference in Italy 4 years ago, it was emphatically advised against intralesional steroids. Okay, all right, fine. So, all right. So we are at the end, and I think we have covered all the questions, all the comments, and everybody said a lovely lecture. I have to also say a lovely lecture. Thank you so much for being with us, for presenting such a thorough job. It was a pleasure to hear you and also to watch your slides, lovely slides.
Thank
And
you.
very well done. Appreciate it. Right? So I hope you enjoyed your experience too,
I
and
did.
you'll
I did.
come back soon.
Yes, I did, ma'am. Thank you so much for the opportunity.
Thank you. You're most welcome. As the last thing to share is next week, we have we are going to talk about ameloblastoma and from treatment beyond the scalpel. And Dr. Yoeta, who in fact is among the audience today, is the one presenting it. And it will be very, very interesting. We also have one event on this Saturday, actually, which I have for some reason forgotten to add. Let me just add it here. Yeah, okay. So, yes, we have the second episode of our journal club with authors. So, this time it's going to be atypical squamous verrucous lesions of the oral cavity. There will be presentations followed by a discussion with the author. Please attend it. And I'm sorry, is it on Saturday or is it? Okay. It is on Saturday, yes, this time. And right. Okay. A little confused because it's not our regular time. It'll take me a few weeks or a few months to get used to that. Okay, that's about it. And with that, let me say bye bye. See you all.